Good afternoon, guys. This is the last part of our OMT lecture series. I will be talking about treating shoulder pain through OMT. Of course, you guys all know me. My name is Dimitri. Just in general, shoulder pain is a very common complaint. We see, roughly out of 1,000 patients, we see maybe 15 times or so. And the lifetime prevalence that a patient will actually have shoulder pain and they'll come see you for, it's actually quite high. I didn't think it was that high, but it's about 70%. Before we get to the OMT part, we obviously need to do a careful history, get the HPI, and some of the things that we can look for are these red flag symptoms that may be a contraindication to OMT. One of which is looking for systemic symptoms. If a patient tells you he's having fevers or night sweats, they've had unexplained weight loss, obviously looking for localized swelling or a mass when we actually examine the patient, if they have a red or hot joint, severe restricted range of motion, which could mean a fracture or a change in contour. Like if the patient has a dislocation, all of these things would be a contraindication that OMT may not be the best thing for them. In terms of our neurovascular assessment of the patient, there's something I looked into that's called a Hoffman's reflex. It's kind of interesting. It is done by flicking the nail of the middle finger and then flexion in the thumb of the and index finger of the same hand that you're flicking is a positive test that can be used to look for signs of upper motor neuron lesions, just like we have the Babinski in the lower extremity. So here is a video of just what it looks like. You can see the patient's thumb and index finger on the right hand kind of flexing when you push on the tip of the middle finger. The innervation of the upper extremity is quite simple. For parasympathetics, like we've seen before, it is the vagus nerve. And for sympathetics, you have the head and neck, which is supplied by the spinal levels T1 through T4. And then the upper extremity itself is T2 to T8. I only put in the head and neck in there just because the top part of the shoulder is right around T4. And also, this is perfect for rib raising for our patients. It's a pretty easy technique. All of us are comfortable with it. It feels good on the patient, and it can help balance between the parasympathetic and the sympathetic responses that we see. The next thing I wanted to go through is just suboccipital release. That's the way that we can target the vagus nerve and kind of balance the parasympathetics with the sympathetics, kind of like rib raising does. And we're all pretty familiar of that and how to do it. The mainstay, I think, of treatment is called the Spencer technique. It's a combination of 8 moves or 8 ranges you can take the shoulder through that helps a lot with adhesive capsulitis, which you could see a lot in diabetics. And even some arthritis that the patient has. If they have been having pain, they stop moving the joint, they get stiff. This will kind of help to get everything nice and loose. So here is the list of all 8. It's a good reminder, and they're all pretty easy to do. They take a few minutes. You can actually incorporate muscle energy into the end ranges of this. And in the next 2 slides, I just have some pictures to go along with each of the steps. So the first picture is, you can tell this shoulder extension with a flexed elbow, and you have the patient push into you with resistance. And like I said, if you really wanted to write that end range of motion, you could have them push for 3 to 5 seconds and then relax and try to stretch them a little further and do that 3 to 5 times. The next step is basically the opposite of that. It's shoulder flexion with an extended elbow. And the same thing, you can do that. You can add muscle energy into it or just have them stretch there for a few seconds to help open up the joint. The next thing is circumduction with some compression. So you're going to push down on their elbow and kind of range their shoulder joint in a 360-degree view. And likewise, the opposite of that is traction with circumduction. So same thing, you pull up the wrist and kind of range their shoulder in 360 degrees. The next 4 of the steps in the Spencer technique are a little bit, I guess, more complicated. This first one is just you have the patient abduct with a flexed elbow and then push towards you, or have them push down towards their body with resistance. The 6th step is basically adduction with some external rotation of their shoulder. And same thing, they're just pushing in resistance. And just like the first 4, you could also incorporate muscle energy into these 4 techniques. Or these 3, the last one you can't really do. But this one is you just have the patient put their hand behind their back, which internally rotates and abducts the arm, and then have them push with resistance that way. And the last step is just for us, it's just distraction. You can stretch them at that point, and this also enhances fluid drainage from the shoulder. One of the other techniques I just wanted to include is called pectoral traction. I just put it in there not because it has any efficacy on shoulder pain itself, but it uses the shoulders, and sometimes these conditions, edema in the upper extremity, some dyspnea, reactive airway disease, or asthma can contribute to shoulder pain, or just pain in this particular area. So I just wanted to put that in there, and basically what you do is you're holding the patient in their armpits, more or less, right at their pec major, and you basically have them inhale, and when they inhale you're pulling with them, and then when they exhale you're kind of resisting the exhale to try to keep their lungs open is the main goal. So those are a bunch of different techniques we can do for shoulder pain. We've seen this slide a bunch of times before. It's just billing and coding. These are all the ICD-10 codes that are present with OMT, just depending on the different regions that we are testing. And in terms of our plan, we shouldn't forget that this is a procedure and we do need to get some consent. So usually for OMT we have verbal consent, and if they're coming to our office for OMT clinic, it's understood that they're going to have some OMT done to them, but still we should consent them and just make sure that they're aware of what they're doing, and telling them what to expect afterwards, with drinking a lot of fluids, taking Tylenol or Motrin if they're sore as needed and if they're able to. And just like any codes, there's CPT codes that go along with it. Depending on how many body parts, body regions you treated, you can add these codes in, the 98925 all the way to 98929. And that is pretty much my whole talk. Any questions from everyone?